fellow at Duke currently. Lizzie's originally from Louisville, where she did most of her training and is actually going back to start a bariatric program. Again, we'd like to welcome Dr. Galvani, and you have the floor.
Thank you, Julie. Thanks so much for the invitation. I think it's a great honor to be here. I was last time with Rana, and it was great. So I hope to, tie up his shoes, be able to tie up his shoes. So should I share the screen?
Yes, please.
Okay, let me see. And I hope you guys can see the slides now. Let me swap it. There you go. Can you see it now on the slide mode?
Looks great.
Okay.
Yeah, it looks good.
Good. Again, thanks so much for the invitation. Happy to be here. This is a little controversial topic, so I try to tackle, and hopefully we'll have a good discussion after I'm done. So these are my disclosures, and I don't think they will affect what I had to say today. So I think one of the important topics to discuss is, why is reflux so prevalent in patients with severe obesity. And I think, many things we know, increase intra-abdominal, intragastric pressure, increase negative inspiratory pressure, mechanically effective LES. But one of the things that are prevalent in patients with obesity is a 40% incidence of hiatal hernias. And you can see here, the transient lower esophageal sphincter relaxations, the lower esophageal sphincter pressure that is decreased, esophageal dysmotility, and of course, the hiatal hernia. So, what is the main issue? What is it that we're faced with? And we have patients that every time I'm about to lift up the liver with the Nathanson, I say, please no hernia, please no hernia, please no hernia. And then, about half the time, there is either a small hernia or sometimes a larger hernia that I knew of and I chose to, repair. So I think it's something that we all think about, and you have 3 or 4 cases in the day. You say, okay, this hiatal hernia is going to take me 15-20 minutes to do, and you just feel like it's getting your way. But I think it's important that we tend to repair these hernias. Why should we do them? There are patients that come to us that already have acid reflux, and we want to help them with that. In patients, there are patients that if not repaired, along with other factors, the reflux can get worse. And there is the question of Barrett's esophagus, or patients that will need revisional bariatric surgery, people that would develop reflux again, or new reflux, people that could develop dysphagia because of the hernia causing obstruction, or something that to me is an interesting term called de novo hiatal hernia. And the incidence reporting literature goes anywhere between 45% to 72%. So, it makes me wonder whether some of those de novo hernias were hernias that were missed at the index operation. But, interestingly, and this is only for sleeves, the 5th consensus conference on sleeve gastrectomy said that the 72% of surgeons in that consensus, that was 120 surgeons, look aggressively for a hiatal hernia during the case. Only 28% of them, they only look for it if pre-op testing or pre-op symptoms were present in the patient. And only 84% of them, it was repaired. So there are a number of people that will find a hernia and not repair it at the time. This is, I'm assuming, that are hernias that are not large. And then, of course, something that was said there at that consensus conference is that the diaphragmatic defect should be closed after the procedure, which, I think it makes sense. And I would do that for sleeves or bypass. So how do we find them? I think it's obvious that either in pre-op workup, depending on what the surgeon's pre-op workup is, pre-op upper endoscopy, or many times found intra-op. When revisional procedures, and this to me seems to be the de novo hiatal hernia, is interesting that surgeons find a lot of hernias the second time around, but not the first one. So it's quite common during revisional procedures that patients will have hiatal hernias. So what do we see? How do we explore the hiatus? This is a hernia that I think is the hiatus seems plagued with fat, with maybe a lipoma. And then when we uncover that, we see that there is a good hole, a good defect. And there is this posterior defect in the same patient that, if I had not taken the pars flaccida, I would have not seen. And there is a lipoma incarcerated in that place. So I think sometimes experience will show you that you have to be a little more aggressive. In these cases, this is an obvious anterior defect, as you can see there, of a sliding hernia. But some of these defects are not so obvious. And sometimes we, choose to say, oh, I don't know if there is a defect. And you see me there poking and convincing myself. And the truth is that many times when I have the exploration of this area, the patient is already in reverse Trendelenburg. So the stomach might be pulling the hernia out of the chest. And this is the typical time when I'm lifting up the liver and I say, okay, please no hernia. And then this patient ends up having a larger hernia than I had anticipated, of course. So not something that I'm looking for. But what we do at Tulane is endoscopies on every patient before surgery, and this is something I've been doing for a long time. So if the patient has LA grade C or beyond, we do not offer them a sleeve. We tend to push them towards a gastric bypass. And if they have a large hiatal hernia, we tend to steer those patients also towards a sleeve, towards a gastric bypass, unless they have a reason that is prohibited for a sleeve, for a bypass, such as multiple surgeries or inflammatory bowel disease. In a study that we did when I was in Arizona, we found that the hiatal hernias were present in endoscopy in about 58% of symptomatic patients and 43% of asymptomatic patients, which was very interesting. And then the hernias were repaired in almost the same number of patients because we knew this from the preoperative testing. And then this is something more recent that we presented at SAGES this year. Regardless of symptoms, the amount of hiatal hernias found in patients in pre-op endoscopy was about the same. So, something interesting is that the bariatric surgery and then paraesophageal hernia repair or hiatal hernia repair, the question is it safe? As safe as it is when we do just the hiatal hernia repair only. And there is numerous studies on the literature addressing this issue. One study that very early on, before MBS equip was created, using NSAIDs, with over 32,000 patients, what they saw is that the number of sleeve gastrectomy patients that had hiatal hernia repair grew from 2% to 14% during that period of time, and the number of bypass patients that had hiatal hernia repair remained about the same. So this is an interesting concept, and we'll address it in a little while. But the only thing that was different in between the two groups, patients that had the repair and patients that didn't have the repair, was the length of stay, and then of course operative time, because they have a hiatal hernia repair. But I wanted to point out your attention to the fact that many of these papers only address paraesophageal hernias. They don't address smaller hernias, and many had said that this is because they don't need repair. So why is it that patients with the sleeve gastrectomy undergo hiatal hernia repair more frequently than gastric bypass? And in this study, you can see 35% in the sleeve gastrectomy patients, 20% only on the gastric bypass patients. And this is something that we were trained with. We're told that the sleeve gastrectomy is not an anti-reflux procedure, and patients are likely to develop reflux. So we will do anything to prevent reflux in the future. What about gastric bypass? if we don't treat hiatal hernias in these patients, potentially they could develop obstructions, they could develop dysphagia, they could develop reflux. And, if they have the pouch hernia along with the small bowel in the chest, they could develop a small bowel obstruction. So something that we have to keep in mind. And then what techniques should we use to take care of these hernias? In this study, it's interesting, the 74 surgeons did 7,800 cases, and they're talking about anterior repair, posterior repair, and posterior repair with mesh. Fortunately, posterior repair was the most common repair used, but they found that the anterior repairs had less complications, any type of complications, but these patients at 1 year had increased reflux symptoms. Nearly half of patients reported symptoms at 1 year. This is different than the posterior repair. The patients had the lowest severity score at 1 year post-op of heartburn. So overall, all the patients did very well in terms of their symptoms resolution, but the patients that had anterior repair were the ones that had the most symptoms after surgery. And this is just for sleeps, but I think applies also if you're doing your hiatal hernias and bypass. So what are my principles of the repair? As I showed you in the video, I explore the hiatus and then decide whether the patient needs a hiatal hernia repair or not. And then the next step would be deciding whether I need to take the short gastrics or not based on the type of surgery I'm doing. So if I'm doing a gastric bypass, I tend to avoid taking short gastrics because, sometimes the fundus could get a little dusky and I prefer not to take it. So I would do the hiatal hernia without taking short gastrics in a gastric bypass. And then if depending of the size of the hernia, we will have to do an extensive dissection into the mediastinum, removal of the hernia sac or the fat pad if it's there. And then I reassess if I have enough length. Of course, it's not the same as the length that you're looking for a fundoplication, because you don't need to create a fundoplication in these patients, but ideally you have 2 to 3 centimeters of esophagus below the diaphragm without pulling on a Penrose drain. And then, of course, I always close the crura posteriorly, but I always do it after completing the procedure. And I think that something I learned is that even if you trust your anesthesia person, they could always push the bougie too far down or too quickly. So if you had closed the crura, the bougie is going to put weight on the esophagus and end up hitting the backside of the crura. So it's better to close it after you have completed the procedure and there is nothing else you had to do for the esophagus or the stomach. I always do the posterior. I do barb sutures. I tend to avoid anterior at all costs. And of course, I use mesh selectively depending on the defect. And then, of course, the next step of the procedure is going to be the sleeve or the bypass or SAIDs or whatever I'm trying to do. So these steps I try to follow also in revisional cases. And I tend to scope every patient after the case. So in terms of my port placement,
Totally robotic single quadrant gastric bypass, I use 4 robotic trocas and 1 bedside.
Sorry about that. The slide is recorded, but the port placement is pretty much 13 to 15 centimeters for the costal margin for my first port, which is the one number 2 listed here, and I will go across the area to the left and the right of the umbilicus. I use a Nathanson retractor for my cases and 1 assistant port if I'm doing a gastric bypass. So that's the port placement. And this is a typical case. This patient is to have a gastric bypass. You can see it's a good size hernia. I wouldn't call it huge, but definitely a hernia that I want to repair. I have a BCG. Anesthesia has placed a BCG and, do some insufflation through the BCG or definitely the stomach was kind of large at that time. So I'm trying to deflate it and bring the oxygen they push into the BCG to deflate it. So then once I'm happy with the way the stomach looks and I'm convinced that I'm going to fix this person, then we start with the repair. And this is I start with the laparoscopic camera, and this is the case without taking the short gastrics. We're going to start on I do start in the left cruise. I don't think it matters whether you start on the left or on the right in these smaller hernias. In larger hernias, I tend to start on the left just because I want to avoid the left gastrics on the right cruise. So taking down the hernia sac from the left cruise here, and then creating at the same time a window for my pouch that I'm going to do after I complete the hernia repair. So do an extensive dissection here on the left side of the esophagus. I have my left hand over here on the left hand side of the esophagus, protecting the esophagus from my right hand instrument. Now we have moved to the pars flaccida and the right cruise, and we're going to try to separate the esophagus from the right cruise. You can see they're pointing the vagus nerve to the student or the resident that is with me in the case. So this is my dissection from the other side that I found and I take advantage of, dissecting to the accusation of the crura. You can see the sponge and the retrogastric window. Ideally, I try to protect the peritoneum on the crura. I think it helps with the closure. And I tend to do in most cases. You see that left crura is now great. So the video-based assessment probably will hurt me when that comes out. So I'm here dissecting posterior and right. Now I'm going to go inside, flipping the scope upside down, and continue the posterior dissection. Now the aorta is at the bottom of the screen over here, and then the esophagus is at the very top. And we continue this dissection proximal. This person did not have a huge hernia, but I like to do, once I start dissecting, I guess I have to stop myself doing it. But again, you see the anterior vagus nerve. So now we're going to do left and anterior on the esophagus. Again, flipping the scope. Now the esophagus is at the bottom and the heart is at the top. And then separating the esophagus from the heart. Not one of my more fun moments of the case. And then once I'm completed the dissection, I think the esophagus stays down. Then I'm going to try to do mobilize this fat pile. I don't like to fire stapler across the fat pile. So for the most part, that's what the case is. And then, of course, we go into creation of the pouch. So I think the next case is a little larger hernia, where we're starting on the same side, but in this case, what we're trying to do is a little deeper dissection. So we're going to try to go more proximal in this case, something very similar to what I showed you before, but there is a formal sac. As you can see here, we're going to try to dissect that sac off the diaphragm, and then use a Penrose drain. And when I have a larger hernia, I want to make sure I'm able to retract the esophagus better, and using the fourth arm as to the full of its capacity. So here you see now the right side, find the Penrose drain on the other side, and then encircle the esophagus once I'm ready and I'm able. But what I try to do is put the Penrose drain always above the left gastrix to avoid injuring the left gastrix. And I had marked that grasper in order to see if I could learn, how far the instrument is going. But we're trying to mark into 10 centimeters or beyond and see if we can, accomplish that. So this is the esophagus. Dissection is good. We're using. My fellow wanted to see if we could see the inferior pulmonary vein, so we injected ICG in the chest. injecting IV in the patient, and you can see it there in the chest. That is that's a pretty cool view, but I don't know if it's necessary all the time. So now completing the dissection, sometimes you can end up injuring the pleura in this patient. You can see there the posterior vagus nerve on the right side of the esophagus, and then dissecting now on the top anterior. So once the dissection is completed, we might choose to take the hernia sac in order to gain more length of the esophagus. Of course, trying to avoid the anterior vagus nerve. You might say, if you're doing a gastric bypass, does it really matter? I just like to protect those nerves at all costs. So here we're taking the hernia sac, and sometimes you tend to gain a centimeter or two. And in this case, we're going to use, again, the V-lock suture in order to close the crura. And then we're going to reinforce the crura closure with mesh. I only use, mesh in hernias that are larger than 5 centimeters, redo cases of patients that have gastroparesis and need this redo hiatal hernia repair, along with a conversion to a gastric bypass. So this is the completion of the case with the mesh in place. So the different thing that you might see in this case is that the mesh is placed in a reverse C configuration as opposed to the U shape that is, so the mesh is looking at the right crura. So I think the true incidence of hiatal hernias in bariatric patients is underestimated, and the convergent repair seems to be safe and feasible. Surgeons should be a little more judicious in seeking out and aggressively treating hiatal hernias at the time of bypass and sleeve gastrectomy. And because of the limiting data, different crural closure techniques, a gold standard does not exist, but a strong consideration should be given to performing a posterior repair ideally. Thank you so much for the invitation.
Thanks so much, Dr. Galvani. I was super impressed even by the slides, because I guess I didn't know a ton of that information. So thanks for sharing. I do have a bunch of questions for you, and we have a couple coming in from the audience as well, so I don't want to kind of focus on mine. But the first one is, can you talk a little bit about your decision when you see the small hernias? So you lift up the liver and there's just a little bit of a dimple there. What kind of techniques do you use to determine how big the hernia is before you do the dissection? And then what kind of factors do you take into consideration when you're deciding whether or not to fix it?
Yeah, great question. I think it's sometimes it could be challenging, like the case I show you where there was the hiatus was plagued with a huge lipoma. So I don't go to the extent of taking down the phrenoesophageal membrane. If I take the phrenoesophageal membrane, it's because I'm repairing the hiatal hernia. So I don't think it makes sense to go to that extent. But if I see an elongated phrenoesophageal membrane, and then I know I had done an endoscopy on the patient, and if I see that an endoscopy we saw a hernia as well, then I'd probably be more prone to address the hernia on that particular patient. And I would hate to leave it behind. But I don't do anything actively. And I think it's sometimes easier with the sleeves, because you could take the short gastrics and look at the posterior aspect of the left crus, and then see, if you have esophagus coming across the diaphragm, or if you have a dimple in the back, sometimes you could see those posterior hernias that are difficult to see otherwise. So with the sleeves could be easier to find a hernia sometimes. But it's tricky. I don't think it's easy, and I don't think I have the final word on it by any means.
I have a question kind of adding on to that. What role does the patient's BMI play into your decision making on whether or not to fix it and whether or not you think any preoperative symptoms would resolve just by weight loss alone?
To me, none. Regardless of the BMI, I think the person has a hernia, whether they have a BMI of 80 or a BMI of 35, I would try to repair it. Of course, doing a male with a hiatal hernia and a BMI of 80 or 60, it's not going to be the same as a lady with BMI of 35, right? But I don't think I use BMI to guide my decision to repair a hernia or not.
I have actually seen you close these hernias and they look really great. But the first time I saw that, I thought it was a little tight, honestly. And since then, I have to say I've been following you and I have been doing it. But my question is, do you see a ton of dysphagia in these patients in the long term?
Long term, I do not. Short term, sometimes I have a hard time to assess whether the dysphagia is from the surgery or from the repair. I tell you that over the last 3 years, I had to take one patient back. This is a patient that had a sleeve that was converted to a bypass by me. And we did a hiatal hernia repair on this individual. And her esophagus was, more dilated than I thought. And I had to go back and take a couple of stitches from the crural repair. And the patient got better immediately. So I think, right now you might say, how do you choose to close this tight? And for the most part, I'd eyeball it. I had done a few hernias in my career to know what is good. And I scope the patient after surgery. So to make sure that I'm not closing it to the point they can't swallow saliva. So I think the crural closure, we know is part of the anti-reflux mechanism, from foregut experience. So definitely a tighter crura is definitely better. And the last thing I want is a sleeve or a pouch herniated in the chest, like intrathoracic sleeve or anything like that. I think I'm trying to hopefully prevent any of that.
So there's one question from the audience, and then I think probably some of our panelists want to chime in, but it's asking about the large paraesophageal hernias. Do you think doing a posterior repair angles the esophagus at all? What are your thoughts on that?
Yes, it does. I think, the truth is that we have the patient on an awkward position. People do not live like this. In reverse Trendelenburg and laying on the bed all the time. During the case, that's what we see. Honestly, what I show you in the videos is what I've done for the longest time. And I do not see patients having issues. The main issue that you would see is dysphagia, right? And every bariatric patient, regardless of hiatal hernia or no, they do have a tinge of dysphagia. Of course, if you repair a hernia, I warn the patient about it, and they probably have to be careful what they do or don't. But the angulation, I don't think is the main issue. When I do fundoplications, I see that the crural closure is rarely the problem. What is mostly the problem is a fundoplication that is too tight. So I haven't had, regrets, honestly, with the posterior closure. And there are probably in the online 1,000 people that do anterior closure, and they haven't had regrets either. But I guess it's a matter of what you're comfortable with and experience, I guess.
And I do think crural closures that are a little on the tight side are pretty amenable to dilation. So.
Yeah, I agree.
Carlos, I just wanted to say thank you for that talk, and those videos were beautiful.
Thank
I
you.
think there's a lot to be learned here, and the nuances of hiatal closure it's so finessed, and it takes so long, I think, in your mind's eye to understand what a good posterior closure is. I totally agree. I do a posterior closure if I'm going to fix these. That's what I do. Lizzie's probably asking that question about BMI because of me, because I have a long conversation with the patients preoperatively about, hey, if we get in there and I think I'm going to maybe cause more harm than good in your BMI of, 55 doing a bypass and you have a 3 centimeter hiatal hernia, maybe we should wait until your BMI is 35 and come back. So just for the fellows, that's a conversation that I think you should have with the patient if you've done a preoperative endoscopy and that's an issue. I think, coming back once they've lost the weight is a really good option as well. The question that I had for you, and I think somebody else already asked in the chat and the Q&A meanwhile, I really am interested in seeing if endoclip is something that is useful here. There's a lot of data on it. And I was wondering in your hands, if you've used it, if you want to use it, like, what do you think about it in this setting?
It's in my wish list.
Yeah, same.
I don't have it in the OR yet. I think it would be useful. I don't know if I would use it every case though, because I think it would probably slow me down. There are cases when it's definitely a must. There are cases when, and I think maybe revisional cases, patients that had lap bands, patients that had sleeves for a long time with dilated esophagus. There are cases where you say, okay, this is a must in bariatric patients. But I have not used it. Some of the data that I quoted on the crural closure being is a significant part of the anti-reflux mechanism comes from endoclip. So, like you can dissociate the crural closure with the fundoplication in anti-reflux surgery. So, of course, you could do the same in bariatric patients, but I have to use it. And I love to work with it and make my own experience, definitely.
I do think, though, when I put that one extra stitch in the posterior closure, and I think to myself, did that go too far? Did I, maybe not, maybe should I take that out? I think the endoclip would be really useful there.
Yeah, because you have, that answers your question, right?
Yeah, exactly. Objective data. Yeah, absolutely.
Because eyeballing sometimes does not work. Depends how your eyes are that day.
When you do your crural closure, do you do it over a bougie? And if so, what size are you using?
So I do not. I do it's interesting because when I do fundoplications or anti-reflux surgery, I do use a bougie. I do use a 56 range bougie. I do not have the bougie in the esophagus when I'm closing, because I think it's bulky. I could really damage the esophagus with the back of the needle or with my instruments. So I bring the bougie after to make sure the bougie is going in and out. So I don't like to have any instrument inside the esophagus as I'm closing the diaphragm or dissecting the esophagus. But I have grown not to use bougies during the closure of the diaphragm. And I think it's a good point, going back to the endoclip. But once you do it all the time and you get used to, the esophagus not being squeezed by your stitches, leaving, a little bit of like 5 millimeters beneath the esophagus, a little room for the esophagus to expand. Those are the things that I use. Is it objective? Zero. But I think as you do more hiatal hernias, then you develop some sort of eye to see, what you want, or when you think it's too tight, or when you think it's too loose. So it takes a little bit, but that's what I do.
Carlos, Adrian, Dan here. I have a comment and a couple of little questions, technical questions. So the comment is that I learned this lesson very much the hard way, and a nuance that could easily be missed by the fellows is to close your hernia after you've done the sleeve. And what I did about 3 years ago, I closed in. Sure enough, I saw what looked like a bougie pushing against the right cruise. They pulled it back right away. And I thought we were okay. My hernia was already closed. And of course, the next morning we were back fixing an esophageal perforation. So, you know, the dissection of the esophagus makes for lack of better words, that there's nothing stenting the esophagus, and it's just a setup for a perforation with a tapered bougie. So thank you for making that point. My questions are technical questions. Number one, the mesh that you used, is that, I don't want to use brand names, but is that one of the newer meshes that's been introduced? And I think I know what it is. Maybe you can tell us maybe the generic name. And then the other thing is, I saw you close it with sutures against the right cruise, but what do you do on the left side? You just kind of leave it, or is it secured there in some way? And I also really liked that little Penrose lasso that you made. So maybe you can tell us a little bit about that.
Okay, so you know, the first question is about the mesh. This is a bioabsorbable mesh. They tell us that this mesh reabsorbs in 6 months. You know, it's a sort of a cousin of BioA. So that's, I don't know, you know, what it's made of. I would probably make a fool of myself to trying to tell you what it's made of, but you know, this mesh is it's better for me because I cut it. So I could tailor it to the diaphragm of the patient, as opposed to BioA that comes pre-cut, right? And the way I observe BioA is that, you know, it was open too much. The U was opening too much, right? So it wasn't addressing the anterior esophagus, the anterior crura, sorry, the anterior diaphragm. So, so I struggled with that, and I stopped using the mesh for a while. So the second question was, I forget.
How do you use your left cruise?
So no, I do 4 stitches for so 2 stitches on the right cruise and 2 stitches on the left cruise. And the main purpose of those stitches is for the mesh not to come into the esophagus. So I want to keep the mesh off the esophagus. So I'm setting the boundaries of the mesh to make sure that you know, if the mesh is not going to hurt the esophagus, and it could still do it, but that's why I do it. And then the Penrose, you know, this is something I learned from, I don't know if it's good or not, but I learned from Facebook, and my kids probably will be cranking up about it. But, you know, somebody I saw it doing in Facebook, and, you know, and I learned a lot from people. I've been doing this for a while, and I can tell you that I still learn every day new things from others. So I'm keep an open mind. But the main thing is, you know, creating a slit on both sides of the Penrose, and then passing the other Penrose in between, and then just so you don't need clips. You know, the clips sometimes come off and everything. So this is like a 1/4 inch Penrose cut to 15 centimeters, and it works every time. I love it.
Thank you, Carlos. Wonderful videos and presentation. Thank you.
Thank you, Adrian.
So there's an interesting debate going on in the chat, which I'll get to next, but I do want to ask a couple of the other questions first, since they came in earlier. Do you think there's any difference in terms of recurrence, whether you do an anterior versus posterior closure?
You know, I don't think I have data on it. So not solid data to the point that we can say this is what we should be doing. I think there is more experience with posterior closure, and there are more surgeons doing posterior closure. You know, the truth is that if you have surgeons that are only bariatric surgeons, and they would go anterior many times, but you have surgeons that have some foregut experience or do foregut surgery at the same time, those surgeons would tend to close posteriorly. So I don't know, you know, I show you the data and that is data from Michigan Collaborative, showing that the patients at 1 year after sleep had more reflux symptoms compared to posterior closures, despite the fact that the patients that had posterior closures had less reflux to start with. So, you know, that's kind of some evidence, but maybe not that strong.
If you're doing the dissection and you encounter some really large vessels in the gastrohepatic ligament, how do you address that?
So I divide, you know, there is always the best question, this question about, there are people that divide the right accessory or not, and people that, you know, work around the vessel. You know, in my fellowship, I was shown that we could take it, and so little, small, huge vessels, and you know, if I think it's big enough that the instruments that I use won't cauterize it enough or bipolarize it enough, then I would clip it. But I always divide it. I don't know if I could do what I do, the dissection I do safely into the chest with that vessel hanging around. So I do divide it at the very beginning of when I go through the pars flaccida. And you know, thankfully we haven't had significant liver necrosis or liver damage or anything like that. I have more problems with the liver retractor than I had with dividing those vessels.
How do you feel about pexying, like doing an esophageal pexy at the end of the repair?
I think that's a terrible idea. You know, back in the day, there was the conversation wasn't with sleeves, it was a lap band. So I'm old enough to have done a ton of lap bands, and there was some data from Mexico coming that they were, you know, pexing the stomach. So they do the gastric stitches between the band, and then they would take the crura at the same time after repairing a hiatal hernia. So I think you know, the diaphragm is one of the most active organs that we have in the body. So patient throwing up, patient coughing, you know, it could rip off the esophagus. So I would not. I think it's the only time I do that is when I'm doing esophagus J, that I pexy the esophagus to the stomach, to the crura on both sides, but for the esophagus not to retract. When I finish the case, I take those stitches down. I don't think the esophagus should be pexied to anything if you want to keep it working.
I would echo that 100%. All it takes is one time of watching your patient wake up nearly levitating off the table, and all you're thinking of is, I wonder what's happening to those sutures.
Yeah.
Yeah.
I happen to think that way when there is anyone a hernia repair. But
immediately put your hand on it, right? But you can't put your hand on the hiatus.
Yeah, I agree. It's a good question, though. There's a ton of questions in the chat.
Yeah, we're going through them. The next one is how do you manage a short esophagus? What kind of techniques do you use for that?
Can I think we should start with our fellow moderator here. I would love to hear what Lizzie has to say, because I think this is a really great fellow level question of, all right, you got a short esophagus, you're trying to dissect, you're trying to get that intra-abdominal length, Lizzie. What are some tricks? What have we taught you this year?
That's very unfair to put me on the spot.
Well,
that's my job.
You shouldn't have changed your name on the.
Exactly. Are you directing the question toward Dr. Jane Spangler, who is also?
You should have left your name as me. Lizzie shared my link earlier, and we realized that it brought her up as Dr. Jane Spangler, which I told her she should leave it as.
Absolutely. So just carry the dissection further up into the chest is how I would get additional length to complete the surgery. just carry it as far up as you can. I think probably from a robotic standpoint, it's probably a little bit easier to do that, to get up as, higher and higher with improved visualization. If you're doing it laparoscopically, I think it becomes a little bit more difficult to be comfortable dissecting that high and be able to feel confident that you can repair any kind of injury that you might cause. That's kind of what my thought process is. The higher and higher I get, the extent of my superior dissection is, or my mediastinal dissection is, at what point does it become too difficult for me to repair something that I might esophagus?
So then if the esophagus is still too short, is there anything else that you can do to the stomach?
You could do a callus gastroplasty. I've never done one of those before, so I'm not sure I would willingly do that, but that is an option.
I'll play the role of the old board examiner. So that still doesn't work, Lizzie. What next?
This is so fair.
Oh, you're mean.
Abort the procedure? I don't know. I'm not sure.
Carlos, please comment on this. I'm not sure how popular this is or acceptable, but I've heard of dividing the vagus nerves purposely to get about an extra centimeter from each of them. Is that something you've ever done or would consider? I haven't, but I know it's a bailout option.
There is some data from University of Washington in Seattle that they have published on this matter. I think there are different things, as you mentioned, dissecting further up into the chest, but if it doesn't still come, I'm not sure. Dividing the vagus nerves definitely, but I would start thinking now, what bariatric procedure am I offering this patient, right? So I changed my mind completely if this person was set for a sleeve, because a sleeve could turn into a very long esophagus. Not necessarily the one you need. So for this person, I probably work on a bypass, and I would use the bypass as my lengthening procedure. Then you have to choose, what kind of pouch you want to use. If you want to use a short pouch, a long pouch, but my preferred lengthening procedure in this situation would be gastric bypass.
How do you feel about the callus gastroplasty?
I feel terrible.
I echo that.
So, it's true that if you ask a thoracic surgeon will give you a different answer. You ask general surgeons, that tell you, 3-4% of the time we use it. But the trade-off, I think, is what I struggle with. I had converted a number of patients that had 2 or 3 fundoplications before, and they ended up getting a colitis by a thoracic surgeon, and then still had problems. Like now they have dysphagia, they have reflux because you have an acid-producing stomach that is part of the fundoplication. So ended up converting the patient to recently, actually, a couple of weeks back, the patient to gastric bypass. And, these patients are not going to be perfect, right? But the truth is that you're making them better. So you're taking reflux, you're taking bile out of the question, you're taking acid out of the question for the most part, or decreasing the amount of acid they're going to have. So my preferred, again, I don't want to be repetitive, but I think I would still go with gastric bypass if the patient is willing to do it. So I tell you, probably I may do something like a colitis, like a wedge gastroplasty, once every 2-3 years.
I agree. And I think that the idea of a callus it's really supposed to be very short and maximum 3 centimeters, because you don't want it to be longer than your wrap, which you're not doing a wrap in a sleeve or a bypass. But I guess in my experience on these revisions is if you do a high mediastinal dissection, 100% of the time, I will get to a plane that hasn't been touched by the prior operations yet. And then you can get enough length if you just go high enough.
Yeah.
There was a question in the chat about a patient who has a BMI of 36 no diabetes, and has an entirely intrathoracic stomach, including the pylorus in the chest, and they do not want to bypass and only want a sleeve, what would you do?
We have a beautiful medical weight loss clinic. And then hopefully there won't be there will be no issues with them to be able to get medications that work. And then as a matter of, I'm working at 2 or 3 patients into this path because of the elevated BMI. So the patients are actually, a person yesterday said, well, we're going to kill 2 birds with 1 stone, because I'm going to, lose the weight, and then you're going to fix me, fix my reflux.
So Carlos, if Adrian was your board examiner again, so he did write that this patient does not have diabetes. So that disqualifies them for Mounjaro, Wegovy, Ozempic, the majority of the meds that are actually effective. Let's say they have hypertension and they cannot be put on Adipex. Then what do you do?
So you mentioned Laura mentioned that the patient does not care for a bypass, you said, right?
The patient
Yes.
prefers not to have a bypass.
She wants a sleeve. She specifically wants a sleeve.
So if I have the diagnosis of objective diagnosis of reflux, or I have,
Let's say you did a Bravo and the Demister is like 55.
yeah. So I tell you, I do not give that patient a sleeve. That patient can go someplace else. I mean, probably they will do that. But I don't think, I would hope the patient can understand that reflux is a medical condition, as bad as diabetes, as bad as any other medical condition, that sleeve is not an anti-reflux operation. And bypass is not the perfect anti-reflux operation, but it's a better one than sleeve.
I don't know about you guys, but every time I have this patient and I sit down with them and I say, this is the data. So, we've studied this and this is what we found, and we do outcomes research for a reason. And this is what our data shows. And this is the best data we have. It's not great, but this is what it shows. They'll pick the bypass, 95% of the time. And the other 5%, they're going to go somewhere else maybe and get a sleeve. And then they're going to have complications that end up back at our center. But I think the onus is on us to really give them the best operation for them, and a low pressure, drainage procedure, because they're already going to have esophageal dysmotility, like Laura pointed out. That's just, if you give that patient a high pressure sleeve, they're likely going to have complications even once you fix the hernia.
100%.
And Nora, in addition to that, I think another thing needs to be taken into account is the consequences of a recurrence of somebody that big of a hernia, and the differences in managing a sleeve gastrectomy in a recurrence versus a gastric bypass in a recurrence, which neither of them's fun, but a lot fewer consequences with a intrathoracic pouch than half a sleeve.
That's a great point.
Another issue is that I think we as surgeons have gotten a little too comfortable with telling patients, oh, you can have something else later, and then end up giving the first procedure is the wrong one for many patients. So this individual that Laura and Kunal bring up, I think is a person that should not get a sleeve. There is enough evidence in the literature to demonstrate that they would not do well, and then they can get worse reflux after the sleeve. So, there will be some surgeons that will do it, and hopefully the patient will, as you said, when you sit down with them and give them good data and good information and build a good relationship, they will go your way.
I don't know that, my impression is that patients don't really appreciate what severe GERD is. It is absolutely life-limiting and is extraordinarily painful. And people who have it cannot live like that. And desperately want you to convert them to a bypass and will do anything to make it happen.
Yeah.
And that is what these people are putting themselves at risk for when they try to insist on a sleeve when they have a big para. And so I just say no.
Yeah.
So I think
100%.
we're all going to copy that clip of you just saying that and play it to people over and over, Laura.
And it's also true what Dr. Dan mentioned about trying to redo paras on patients with sleeves is that sleeve staple line absolutely sticks to the mediastinum, and those are hard to get out. I mean, you just have to sit there and like chop at it for an hour because it's like concrete. So those are not easy cases, and it's not something to just say, oh well, no problem, we'll just convert you later if it comes.
No, I think that's a bad choice, bad idea. And then, you know, if you have those surgeries that, and again, you know, there are people that like to put clips on sleeves throughout from the top to the bottom, and those clips in the mediastinum are not fun. They're like, you know, it's a battle, and there's blood all over the place. If you had gone through that case, you can relate to it.
For patients who have a recurrence after a sleeve, and they come back with reflux and a recurrence, what's your algorithm for just fixing the recurrence versus fixing the recurrence and converting them to a bypass?
So, you know, that's a great question and a great dilemma that I go through every time the patient like this comes. You know, most patients, I'd say probably in the 70-80% come with some weight regain at the same time. And then they have this severe reflux. And you know, to your point, Laura, patients that I treat patients with reflux, and I've done that for a while. The patient that has reflux after a sleeve are the worst, the people that suffer the most. But you know, I would do a full workup on those patients and try to help them understand. I have done gastric bypass in a patient that had BMI 25, BMI 27, and Barrett's. You know, it was a difficult conversation. Patient didn't want it, but there was not much else. And then I tell you that you might say, you know, there is now links, and you know, something that the ethical people have put out is that reflux is not heartburn, and you know, I kind of relate to that. But you know, this is going to the sleeve links. You know, if you read that publication that came out, you know, the results are imperfect. The results are they have a lot to wish for, and you know, somebody told me that they're not going to continue that trial for a sleeve or links on sleeve patients. So they don't have a whole lot of good options. And you know, you can argue you can go preemptive to the Nissen sleeve that the people in France are doing. I'm not sure if that is a great solution because you're doing it beforehand. But you know, unfortunately, the only option those patients have is gastric bypass.
So I think we have been making a very compelling argument for the bypass, but you know, there's always going to be that patient who is not such a great candidate, right? This was raised in the chat. Patients who are smoking or who are relying on NSAIDs. I mean, how do you manage those types of patients, right? Like you have some reasons to want to do a bypass on them and others to not want to.
You know, that's a tough question, and I don't know if I have a great answer for it. Because you know, the optimization of the pre-optimization of these patients is key, right? But then how can you be assured of compliance afterwards, like smoking, for instance, or people that have severe arthritis that need NSAIDs? You know, these are complex patients that they're difficult to compromise. And they might want to do it, but then they have, you know, smoking cessation is tough. So I think it's difficult, but you know, sleep, I'm not sure it's going to be the solution, because if you had to down the road convert those patients to a bypass, right? Then you're stuck in the same place. So I don't think there is a straight answer on this, and I mean, I hope you guys have it, and I can have it. I would love to hear.
So I think the question in the chat asked about 3 different things. And so for the smoker, if you look at the data, there's actually a pretty high return to smoking rate for active smokers at the time of their first visit. And so I try to avoid bypassing those patients, to be honest. I live in North Carolina, so I'm lucky. I can do duodenal switch and NSAIDs probably more often than other people. But I do try to offer these patients, a sleeve, if they need more weight off, a NSAID or a switch. NSAIDs, a little bit of a different story. It depends on, people who are migraine, like lifelong illness dependent versus I need to get a new knee and I need to get weight off to do that. And so it's going to be a limited period of time in which I have to find an alternative pain regimen. So that's kind of one of my considerations there. But again, if you're going to be on lifelong NSAIDs, I'm going to give you a sleeve or a NSAID. And I think as my partner, Dana Portnier, has taught me, the bypass was our baby. We've done the bypass for so long. It's been the best procedure. It's gold standard, but it has an Achilles heel. And that Achilles heel is marginal ulcer from these things. And waking up night after night after night to go in and repair perforated marginal ulcers has definitely skewed our vision a little bit. And watching patients die of perforated marginal ulcers and sepsis related to that, I think, is something when you have alternatives, you start to consider. So Barrett's, they don't get a sleeve. In my hands, they don't get a sleeve. If they have documented Barrett's, I think that the data is pretty clear that patients who are coming in with Barrett's have reflux severe enough. And so we do a GERD HRQL score preoperatively, and I scope all my patients preoperatively. And if I see anything that looks like Barrett's, I biopsy it. So I do a pretty thorough workup. I think the conversation also needs to shift to postoperatively. What are we doing? So we're doing all these sleeves, and who are we surveilling and who are we not surveilling and who should we be surveilling? So I think the recommendations of, 3 years post sleeve doing an endoscopy is also something that we need to be discussing.
So honestly, Kenora, I think all of those topics could be their own, like hour-long discussion. And I think it would be great for us to continue. Unfortunately, we are already over time. So I guess that's something we'll just put on the books for future happy hour discussions. Dr. Galvani, thank you so much for taking the time to talk with us about this. To the audience, thanks for posting questions and for staying a little bit over. And of course, to the panelists, thank you guys for participating. We will be meeting again in a month, and we'll have a journal club session at that point. What's the topic, Laura?
Sorry. We are going to be talking about looking for jobs in bariatric surgery, which is important.
Paramount. Yeah. All right. Well, thank you guys so much
for that.
Sorry, go ahead.
No, I wanted to thank you so much for the conversation. It was great. I really enjoyed it, and looking forward to more of this.
Great.
Thank you.
All right, you guys. Good night.
And thanks, Julianne and Laura, for the only happy hour where you don't need a designated driver.